Hi everyone, my name is Arnav, and I'm going to be demonstrating an end-to-end workflow of a better patient triage strategy that uses Palantir AIP. Picture this: in the bustling environment of an emergency room, a registered nurse stands at the front lines, constantly making rapid high-stakes decisions and determining which of her incoming patients actually needs immediate hospitalization versus who can wait for their care. Her decision is super important since it dictates the patient's chance of recovery while balancing the hospital's ability to efficiently allocate its resources. Currently, this nurse relies on a basic triage protocol known as RUN-PC, which asks seven incredibly general questions about the patient to evaluate how urgent their conditions are. Most academic studies tell us that these questions aren't enough for a nurse to accurately categorize a patient as either high risk or low risk, hence leading to either patients not getting immediate care or simply burdening the hospital's infrastructure. Here is where an advanced triage strategy becomes invaluable in helping ER nurses determine patient urgency. I leveraged Palantir's Foundry and the ontology I created to offer a data-driven approach that would take patient data and help nurses make a more informed decision on whether or not to immediately hospitalize a patient based on far more sophisticated models than run PC. Here got two data sets that were extracted from PMC patients, a famous clinical data set comprising of 167,000 patient summaries. The first dataset has all the patient information gathered from PubMed, including the patient's age, gender, and notes written by their physician, which outlines that patient's onset, diagnosis, prognosis, and treatment. The second dataset has ICD codes, which stands for the International Classification of Diseases, where each of the 80,000 distinct codes corresponds to a distinct disease. A recent study from the NIH reveals that ICD codes map specific medical conditions extremely closely to the severity of the patient's diagnosis. For example, codes like A066 that correspond to a brain abscess are significantly more severe and rank higher on the triage ladder than the code like A059 for simple bacterial infections. So our goal here is to ultimately create a link between each patient and various ICD codes to get a more comprehensive idea of severity for a patient. To do this, I first run an LLM on each patient that uses NLP to extract a diagnosis from their notes. Then I use another LLM to get potential hospital resources that would be needed during the tenure of a patient. So this includes everything that a patient would need when at a hospital during the tenure. Then I use regular expressions to pattern match strings in the patient diagnosis from the first dataset to the descriptions of the ICD codes in the second dataset to create a correspondence between each patient and all the appropriate ICD codes that best fits their diagnosis. Lastly, based on the patient history and their ICDs, I run an LLM on this combination to get a severity score from 1 to 5, which measures how acutely a patient needs care, with 1 being non-urgent and 5 meaning the patient is highly critical. Thus, just looking at some disorganized notes of a patient, my Palantir pipeline generates numerous informative metrics, such as potential hospital resources, patient severity, and ICD codes, which are all highly correlated with how a patient should be triaged. I added all these features for each patient to my final dataset, which I will use to build my final triage application. Introducing Palin Triage, the one-stop application made for ER triage nurses. First, we import and visualize the dataset that we meticulously built from the Palantir pipeline. In the central console, we have a table for patient information. We initially were only given the patient's age, gender, and physician notes, but we use machine learning models to extrapolate the rest of this information, such as potential diagnoses, patient severity, potential hospital resources that this patient will use, and ICD codes that represents the patient's diagnosis. Furthermore, this application allows nurses to filter patient data to get a better overall picture of the incoming patients. For example, we see that patients aged 10 to 30 have a severity level that's very left skewed, meaning that most of these younger patients have a severity level of 1 to 2, meaning that their condition is not as severe, versus patients that are between 70 to 90 have conditions that are pretty severe, between 4 to 5, which makes sense since older patients are typically in hospice care and they take longer to recover. So this serves as a great sanity check for our severity algorithm, as this is consistent with our intuition. Also, if we generally look at the severity level graph without any of these filters, we see that the distribution is not Gaussian, but more uniform, meaning that the hospitals are getting patients from all severity levels. Hence, having an accurate triage system is even more imperative for us. So next we run the existing triage protocol on a new patient and accompany it with our much more sophisticated triage tool that also uses this newfound metric of severity to make a much better prediction of how quickly a patient needs care. So finally, here's the workflow. A nurse would simply click on the patient and read their notes. Then it would click the calculate triage button. This is the current run PC triage algorithm, which I mentioned earlier. There are 7 general questions nurses currently use to gauge severity. We will use this as yet another metric to ensure that our model is accurate. Full disclosure, I coded this TypeScript function exactly as described by current medical guidelines through the ontology to mimic the real run PC algorithm. So here I will enter some sample data for the run PC algorithm. I'll just maintain everything as somewhat moderate. And I'll say the patient is not imminently dying. So then this algorithm calculates a run PC triage score out of 100, which is currently how ER nurses gauge whether or not to put a patient in immediate hospitalization or to give them time. We pair this with the patient severity, and then the ER nurse has to choose the type of consultation. So we select the type of setting that the patient is in, since the urgency depends significantly on each setting. For example, an inpatient setting requires a long-term hospitalization, so the triage barrier is much larger than the community setting, which are usually nursing homes and preventative care. So for now, we'll just use the in-person unit setting and we click compute. So after choosing the station, we run our model and it outputs a more comprehensive score and dictates whether the patient should be immediately hospitalized or not. It also provides rationale and potential diagnosis, which dictates this rationale. Ultimately, this tool is used for nurses to make an educated decision on whether patients should get prioritized for curative palliative care. The current status quo, which is based off of just asking 7 questions, which is the run PC algorithm, is clearly not enough and has seen a pretty high false positive rate. We hope that such a comprehensive tool will help ER nurses use data to make a better call on patients coming in from the ER room. So here, after we clicked run, we see the score is a little higher than the triage score, meaning that clearly it's not moderate and this patient needs help. This explains the rationale of why it got the score of 45, explaining that the patient has a history of serious medical conditions, including all of these ICD-10 categories, which seem pretty significant. Then it explains the recommended response for the ER nurse, saying that it's urgent for this type of consultation and that admission to immediate palliative care, inpatient palliative care, is required within 48 hours.